to the other folks in the room who were helping to make the simulation more realistic. It is 11:15, so we'll move on to our next and final talk. I want to introduce Dr. Rabia Khan. As I mentioned earlier at the very beginning, Dr. Khan is a pediatric cardiologist and is a specialist in pediatric heart failure. And she'll be talking to us about some of the specific cardiac abnormalities related to MISC, as well as I expect a general overview of myocarditis along with expected outcomes. And so with that, I will turn it over to Dr. Khan, and you should be able to share your screen.
Wonderful. All right. Can you see my presentation now?
We can.
Okay, perfect. Let me make sure that shows up appropriately when enlarged. Is that still good?
Looks good.
Okay, wonderful. All right. Good morning, everyone. It's a pleasure to be here to talk to you about this very important and current topic. If there is a little bit of overlap with kind of your previous sessions, and please forgive me, but I wanted to make sure that I gave a good summary and kind of went through everything systematically. So in the fall of 2020, when I was first starting my career as a pediatric heart failure and heart transplant cardiologist here at UIHC, that's when the hospital began admitting a lot of patients with multi-organ dysfunction that was ultimately linked to either a current or prior diagnosis of COVID-19. And several of these patients actually presented with significant cardiac dysfunction, and it was unclear what level of heart failure therapy they might need, and that's why we got involved. And I sort of had a personal interest in myocarditis, and so I kind of took ownership of this patient population. And this has involved constantly staying on top of the literature, as well as looking for patterns and connections among the patients that we were seeing here. So today I'll share some of this knowledge with you. So here are the objectives that I'm hoping to accomplish in the next hour or next 45 minutes or so. I'll provide a brief introduction to COVID-19 and the cardiac disease that we've been seeing in our patients. We'll distinguish between COVID myocarditis and multisystem inflammatory syndrome, which is also known as MISC or MISC. I will mention why this is important by listing all the serious sequelae that are possible. And then I will describe these two different conditions in detail, the COVID-19 myocarditis and the MISC, and I will talk about the features, presentation management, and follow-up for both of them. We will touch briefly on vaccine-associated myocarditis as well, and then we'll talk about the impact of COVID-19 on children who have existing heart conditions. I'm sure that we all know all about COVID-19 by now, and many of us have experienced it personally or seen its impact on families and on our families and communities. COVID-19, also known as SARS-CoV-2 or severe acute respiratory syndrome from coronavirus. It's affected over 430 million individuals worldwide, with over 80 million affected in the US. The mortality has been about 2%, more common in certain susceptible populations. Death has often been caused by severe acute respiratory syndrome or multi-organ dysfunction. But honestly, the mortality rate alone does not capture the true burden of this viral illness on our healthcare system. Important causes of long-term morbidity have included prolonged fatigue, cough, and dyspnea, which are commonly known as long COVID, thrombotic events such as stroke or pulmonary embolism. In some of the adult patients, we've seen new onset hypertension or diabetes. And new onset POTS-like syndrome has been something that has come up a lot in our clinics, my clinic and our POTS specialists here. We're getting referrals for this almost on a weekly basis. And finally, myocarditis or inflammation of the heart. So in pediatric patients, the heart can be affected at one of two different times. One, during the acute phase of the COVID-19 infection, and secondly, due to an acute ramp up of the immune system that happens 2 to 6 weeks after the acute COVID-19 infection. And that's what we call the multisystem inflammatory syndrome. We've occasionally seen some overlap where the patients initially presented with active COVID infection, but over time kind of showed signs, symptoms, and labs that were concerning for the MISC. So why does this matter in children. I think overall, a lot of people tend to think COVID in children is very mild and usually a completely recoverable condition. So why should we worry about this? Well, I can tell you that, most children do well, but there are children who have suffered some serious and severe sequelae secondary to COVID-19 and across the country. And many of these complications we've seen here at UIHC. Following infection with COVID-19, children have experienced acute respiratory distress syndrome, vasodilatory hypotension, multi-organ failure, thromboembolic stroke, pulmonary emboli, circulatory failure, even up to requiring mechanical circulatory support, giant coronary aneurysms. There's even been some patients who didn't have a previous diagnosis of diabetes or had diabetes that was well controlled and had diabetic ketoacidosis when they presented with MIS-C or COVID. And then there have been cases of death. You may have heard of a recent case in Wisconsin. And honestly, aside from, I think, the giant coronary aneurysms and death, we have seen all the rest of these here at our institution. All right, now I will specifically discuss the effects of COVID-19 on the heart, starting with the cardiac inflammation that occurs at the time of the COVID-19 infection. So this is what we call COVID-19 myocarditis. So COVID myocarditis has been much more common in adults than children, but there have been many cases in the teenage and young adult population that have even been seen by our cardiology group. So it involves myocardial injury with or without cardiac dysfunction that occurs at the time of the COVID-19 infection. The pathophysiology is likely to be very similar to other forms of viral myocarditis, and the damage occurs due to direct injury to the myocardium by the virus, plus probably some sort of immune system or some sort of damage from immune system response. Let's move on. So this first paper here is an early paper from March 2020 that evaluated the outcomes of myocardium the outcome of 150 patients with COVID-19 that were initially seen in Wuhan, China. And of the 68 deaths that occurred in this cohort, 7% were attributed to circulatory failure from myocardial damage. There was this autopsy study in October 2020 by Johns Hopkins and Louisiana State University that concluded that in their case, less than 2% of autopsies of those who died from COVID-19 showed true evidence of myocarditis, but there was a much larger number, actually close to 50%, that showed some mild effects on the heart, some mild histopathologic findings. And then finally, here is a Big 10 COVID-19 cardiac registry study. This is from May of 2021, which included athletes from our own university. And it demonstrated evidence of myocarditis on the MRIs of 2.3% of athletes who had been infected with COVID-19. So, definitely less than 10%, it seems, from all these studies, but still, a significant concern. As far as how these patients present, it can be variable. Patients can have acute chest pain and troponin leak in the absence of cardiac dysfunction, or they can come in with evidence of fulminant myocarditis with severe ventricular dysfunction and cardiogenic shock. There are also patients who didn't experience any of these acute symptoms and actually came in to our clinic as in an outpatient setting. Basically, they recovered from the initial COVID infection and then tried to go back to sports and activities that they were involved in and found that they really couldn't keep up. And there's been quite a few patients like that I've seen. And I initially didn't know what to expect, but when I started to get MRIs, I found that a few of them actually ended up having evidence of myocarditis even months out. And following that, now, if anyone presents with symptoms, exercise related symptoms that start immediately after COVID, I definitely take those seriously, and they definitely can be a feature of myocarditis. Diagnosis is made either clinically or by cardiac MRI. Endomyocardial biopsy is the gold standard, but it's really not used very often due to its invasive nature. So some of the clinical findings that we're looking for these patients are elevations in cardiac markers, so troponin and NT-proBNP, and or cardiac dysfunction. And both of those things usually will improve or resolve either spontaneously or after giving some sort of anti-inflammatory therapies. This paper here is a multi-center collaboration from September 2020 that described the features of COVID myocarditis and proposed some guidelines for management. And I actually found these cardiac MRI images to be very helpful. So they demonstrate myocardial edema in these first 4 pictures. So these bright areas here are edema within the heart wall. And then these are a little bit smaller, but you may be able to see the arrows are pointing. So right under the epicardium, there's some subepicardial scarring here, fibrosis. These are kind of the findings that we see in myocarditis, and it's actually very similar to what we see with general viral myocarditis that we've always seen pre-COVID. So as far as the management, a majority of it's supportive. So, pain control, IV fluids, respiratory support as needed, inotropic support, and mechanical circulatory support. We have had a patient like that, and I'll talk a little bit more in detail about that patient who needed mechanical circulatory support. IVIG can be considered in cases of high levels of inflammation when there's cardiac dysfunction or when the patient doesn't improve rapidly. Although there isn't great evidence behind IVIG for myocarditis, so there are centers that use it very sparingly and some that don't use it at all. Antiarrhythmic therapies may be needed in the case of ventricular arrhythmias. And there's other immunomodulatory treatments that you can consider, like steroids and interleukin antagonists, but we'd want to use those with caution in the setting of an active COVID infection, particularly if there's concerns about other maybe bacterial superinfections. We usually say to avoid NSAIDs in the setting of significant cardiac dysfunction, but if they just have a troponin leak and have normal function, then sometimes the NSAIDs can provide a lot of relief. And there's been some papers that have shown some evidence that it may expedite the healing as well. And then kind of during the recovery post-discharge, some patients may need a steroid taper if they were started on it for several weeks. And then, heart failure therapies, if the cardiac dysfunction persists. Fortunately, we haven't really had any significant amount of cardiac dysfunction that persisted beyond discharge, but it has been seen at other centers. And then exercise restrictions for at least 3 to 6 months. And these are based on kind of the standard myocarditis guidelines that as their heart is healing, they can be at risk for arrhythmias. So we typically restrict at least from sports, and we advise light activity for these patients. As far as longer term consequences for COVID myocarditis, not a lot is known at this time. These are 2 papers from the spring and fall of 2021 that do provide some early insight. Initial reports demonstrate that there was an increase in mortality to 3.9% in those who had myocarditis compared to 2.9% in matched controls who had COVID-19 and no myocarditis. However, this increase in mortality only applied for those who were kind of very sick from the get-go, the ones who needed to be admitted early on with the COVID-19 infection. If they had a diagnosis of myocarditis in the kind of later an outpatient setting, then they were unlikely to have any kind of progression to the point of kind of having a terrible morbidity or mortality. That didn't tend to happen. And let me see. Oh yeah, and then in adults with existing cardiovascular disease, those patients did have some higher risk of cardiac injury and also increased risk of having morbidity and mortality. But longer term outcomes are really not known. And of course, we have a lot to learn as time goes on. So as far as our experience, I follow a total of 8 patients who have confirmed COVID myocarditis. And you know what, I have 2 to see this afternoon that may kind of may add to this number. But all of them are older teenagers. 4 were admitted to the hospital. There were 2 males who both presented in cardiogenic shock. So a little bit of their features. So one of them was actually found to be in DKA. He didn't have a prior diabetes history. And he also required high dose inotropic therapy. And he had significant cardiac dysfunction. He ended up having a cardiac MRI that was performed 2 months post-presentation because he actually needed cataract surgery. So he wanted to see what was going on with his heart at that time before he went in for the surgery. And he was found to have mildly depressed LV function and some hypokinetic regions and patches of myocardial edema. When I see him around 6 months, I'm going to repeat an MRI and see how things look at that point, and see if I can clear him for regular activity. And then the second patient was very, very sick, and he required VA ECMO for a week. He did have some cardiac dysfunction 6 weeks post-presentation when I saw him in clinic, but this did resolve at a follow-up visit that was 3 months post event. There were 2 other patients with milder symptoms that required admission, both teenage females. One of them had bilateral pulmonary emboli, elevated NT-proBNP, and did have fluid overload, but the heart on echocardiogram remained normal and continues to look normal and responded well to diuretic therapy. And then a 4th patient also presented in diabetic ketoacidosis. This one had a known history of diabetes and had a milder course, just had some elevated markers, but otherwise heart looked okay. And then I've had, and I think this number may have increased since I last put this down, but I had 28 patients as of last week who presented with exercise intolerance post COVID-19 infection. And MRI was performed for anyone who was able to tolerate this without sedation, so all of the older children. And I did find 4 who had very clear evidence of myocarditis. At the time that I looked at all of this, there were 8 with tests pending. And so we'll see if what those show, but there may be more in whom and there's also possible that even if the ones who had normal findings on MRI, that the myocarditis resolved by the time we got the MRIs, because sometimes the MRIs weren't done until 3 months or even longer post kind of when they had the COVID, because initially, they just had some exercise intolerance and they weren't sure what to make of it, and it may have taken them a while before they actually were seen in my clinic. All right, I'm going to switch gears now and talk a little bit about MISC, multisystem inflammatory syndrome in children, and it's inflammatory syndrome that occurs 2 to 6 weeks after the initial COVID diagnosis. All right, so this is an early paper. This is from June 2020, and it provides some clinical characteristics noted in patients with MISC. At that time, they had 58 children. It's a multi-center study. And here's a table from that. I'm not sure how well you can see that, and I know it's kind of busy, but I'll give you a little bit of the information. So there's some differences in criteria for MISC amongst the World Health Organization, the Royal College of Pediatrics and Child Health in the United Kingdom, and the CDC. But all of them have a lot of similar things. So essentially, there should be clinical findings from various systems, including a rash, GI symptoms, hypotension, other cardiac findings, coagulopathy. And then there's a requirement of having recent COVID infection or positive antibodies, and then elevation of inflammatory markers. And then finally, there shouldn't be any alternative diagnosis. Here are a couple of images that demonstrate the symptoms that occur from the various systems that are involved. So most common include fevers, mucocutaneous findings that are similar to Kawasaki disease, and GI symptoms. But some other common ones are hypotension, headache, and respiratory distress. And one thing that wasn't really mentioned in either of these images in too much detail was the hypercoagulability and the risk for pulmonary emboli and stroke. So I added that here. So here are some of the cardiovascular findings that we have. So vital signs on presentation often show significant tachycardia, and about a third to a quarter of patients that we've seen have presented with hypotension. This can be seen in the absence of cardiac dysfunction, which suggests that it's mostly a vasodilatory process. Some can present with evidence of heart failure, such as fluid overload and poor perfusion. On echo, the 2 abnormalities that we're looking out for are left ventricular systolic dysfunction, which can range anywhere from mild to severe when it does occur, and coronary dilation. At our institution, we've seen up to moderate kind of diffuse dilation of the coronaries that resolved after treatment. But there have been cases in the literature with giant coronary aneurysm that have taken a lot longer to subside. EKG findings include low-grade heart block and ST changes. There have been reports in rare patients of atrial arrhythmias, particularly AFib. That's not something that we have seen as far as I know. Cardiac markers are often elevated, more often the NT-proBNP than the troponin, but we can see both of them. Even when the NT-proBNP is normal, it does often rise very rapidly upon IVIG administration, which raises concern that there may be some myocardial inflammation and there may be some diastolic dysfunction, but it's really difficult to prove without having kind of a control group. And it's kind of unclear how much of a rise in NT-proBNP is expected even with a normal heart after receiving fluids or IVIG. But there have been patients who have even had a rise in troponin, normal troponin, and then it kind of rose rapidly as their CRP was still in the phase of rising after we started treatment. And then as the CRP started to come down, then the troponin and the NT-proBNP came down. So I do suspect sometimes when patients initially present to us, they may still have kind of cardiac injury that's ongoing, and we may not see features initially, but we may see them as we follow them. Our management includes some supportive care. The same supportive care as described with myocarditis, but these patients almost always get IVIG as well, and most of them have also gotten steroids. And this is kind of due to the similarity with Kawasaki disease and the high levels of systemic inflammation that we're seeing typically in these patients. Some will also receive interleukin inhibitors. We use anakinra here. Some form of anticoagulation is needed for most patients in the acute period, and aspirin may be needed more longer term if coronary arteries are dilated. Antiarrhythmic therapies are only given if arrhythmias are seen, which has been rare. And then after discharge, usually the steroid taper continues for several weeks. Heart failure therapies can be considered, but we actually haven't had anyone have significant dysfunction, prolonged dysfunction. And there are many large studies that have demonstrated edema and fibrosis in the myocardium on MRI during admission. So, we do limit exercise for 3 to 6 months due to whenever there's any concern of any kind of cardiac involvement. Our follow-up frequency here, so we see most patients in 2 weeks and then 6 weeks. I have in the past skipped some of these for mild, the 6-week visits for some of the mild cases with minimal cardiac involvement. But according to new rheumatology guidelines, they are recommending that follow-up, particularly to look at the coronary. So I plan to, going forward, see all the patients at the 2-week and 6-week mark. I have been seeing patients at 3 months and 6 months. And then I do plan to see them at the 1 year and 2 year marks as well. And then beyond that, I'm not really sure what I'm going to do. This is so new that I really need to see kind of how patients are doing as they get out there, what other centers have been doing, and I plan to base it a little bit on that. As far as the exercise recommendations, so anyone who's had cardiac dysfunction, I tend to try to restrict them for the full 6 months. And otherwise, we have tried to clear some patients in 3 months, and so far everything has been pretty reassuring. It seems like this is something that comes on very quickly, but also resolves really quickly. And our MRIs have typically been normal, and patients have been able to go back to activity. So in patients who are 10 and older, typically, sometimes I'll talk to parents and see if we can do it for some of the kids that are 8 or 9. We'll get a cardiac MRI and an exercise stress test. And then for the younger kids who would not be able to tolerate those studies, or especially not the cardiac MRI without sedation, I'll usually do just the standard echo and EKG at that 3 or 6 month mark, and then I'll do a Holter monitor and make sure that with usual day-to-day activity, they're not having any rhythm issues. I so far have thought that sedating a patient is not worth the risk, and so we don't sedate for MRIs for this specifically. If they're going to be sedated for another reason, then I may consider it for the younger patients. So this is what we've seen so far. Hospitalization duration is usually 1 to 2 weeks. LV, systolic dysfunction, the troponin elevation, NT-proBNP, all of these usually normalize by my first visit with them at the 2-week mark. And most patients are feeling better kind of somewhere around that 2 to 6 week mark. They are pretty close to baseline at that point. And coronary enlargement has always resolved by 6 weeks for my patients. There was one patient who actually had it develop a little bit late. They didn't have it during hospitalization, had it at 2 weeks, but even for that patient, it did resolve by 6 weeks. And then, like I mentioned, the cardiac MRIs don't show any evidence of myocarditis at that 3 to 6 month follow-up. And exercise stress tests have also been reassuring, no arrhythmias or ischemia. And in general, what we're seeing now, and this is consistent with what's been seen across the country, that MISC is actually relatively rare, very rare actually, in the fully vaccinated children. We have a couple cases, but it's not nearly as common. A vast majority of what we've seen, of the patients we've seen, have not been vaccinated. But again, long-term outcomes beyond 1 year are not known. So far, it seems like a rapidly resolving condition, but only time will really tell. I follow 57 patients that were hospitalized, either hospitalized here or kind of followed up with me in my clinic. There are 11 that only had cardiac dysfunction, 9 that only had coronary involvement, and then the 5 that had both of those findings. And then here are some of the unusual or kind of interesting findings or different cases. So there's one patient who had a stroke as kind of the first presenting symptom, and is fortunately doing really well now after getting lots of therapies, but had expressive aphasia initially when he presented. There was one patient who has had some dysfunction. Actually, this patient, I would say, was probably the only one who had some dysfunction in the outpatient setting. So there was, when he first presented, he had very poor heart function, around 30% EF. And on MRI, we actually ended up getting an MRI right away because he was one of our first patients and we were still sort of figuring things out. And he actually had the dysfunction, but didn't actually have obvious signs of myocarditis. And then I got his follow-up MRI 6 months later, and he still had some mild dysfunction, and again, didn't have features of myocarditis. He has been lost to follow-up, unfortunately, but I'd really be interested in knowing kind of how this evolves over time and whether there may be some other features, something else going on in him. There's 2 patients who had a history of Kawasaki disease and 2 patients with the history of HSP. So, not enough to really say much, but I've always wondered whether patients who've had other kind of inflammatory conditions in the past may be at higher risk for this condition. There was a patient who had a family history of cardiomyopathy and 2 family members. One of them had to have a transplant, and the other one actually passed away from the cardiomyopathy. But this patient has done well. There's one patient who actually didn't receive any treatment because he was kind of rapidly improving, even by the time we saw him. I think we got him from another hospital, and his labs were already improving, and he did really well. I continue to follow him, but I haven't had any concerns for him. There is some patients who have some prominent left ventricular trabeculations. I'm not sure if they're going to meet any criteria for cardiomyopathy, but I'm keeping an eye on that. There's one patient who had prolonged tachycardia of unclear etiology. We still don't know what's causing that. I've looked at his heart many times. I've done Holters, and everything checks out okay, and it's just sinus tachycardia. And then the diabetic ketoacidosis, again, in a patient who had a known diagnosis of diabetes. Another thing that I'm seeing more recently is that a couple patients who had MISC later either got COVID again or got another virus, and then they didn't have any findings on echo, but both of these patients had really dramatic changes on EKG, which makes me wonder if at the time when their hearts are still healing, maybe they're at higher risk of further cardiac injury with another infection. All right, just brief discussion about vaccine-associated myocarditis. So the COVID-19 vaccine became available for the 12 to 15-year-olds in May of 2021, and that's when this phenomenon came to national attention within kind of a few months of that. Although, it's actually been seen in young adults well before that. These are several papers that discuss vaccine-associated myocarditis in detail, and I'm just going to summarize the important points here. So it most often developed after the second dose of the vaccine. There was a male predominance, mostly seen in that adolescent and young adult population. The features included chest pain and troponin elevation. Some had ST changes on EKG. Cardiac dysfunction was not typically seen in these patients. Cardiac MRI was suggestive of myocarditis in everyone who was tested. Hospitalization was typically less than a week, and recovery, complete recovery with normalization of labs occurred in 2 to 3 weeks. And then as far as the younger patients, the 5 to 11 age group, there was concern when the vaccine became available for them, but we really didn't see a lot of myocarditis in this age group. In fact, based on data released by the CDC in December, out of thousands of children who received both doses of the vaccine, there were only 11 confirmed cases of myocarditis in this age group, which is much less than what we were seeing with the teenagers. And so this raises the question about whether this adverse effect may have been dose dependent, just because the younger children did receive a smaller dose of the vaccine. As far as I know, there's only 2 patients that had clear confirmed cases of vaccine-related myocarditis, and I follow both of these patients. There may have been another 1 or 2 that are followed by somebody else, but these are the ones that were pretty classic findings. They were both admitted for chest pain a few days after the second vaccine dose, found to have a troponin leak. One had an MRI during the hospitalization that did show the LGE and edema, and the other we just made a clinical diagnosis. Both were discharged within 3 to 4 days, and on follow-up MRIs in 6 months, neither of them had any edema, but both of them did have some very minimal LGE. Definitely for the one who had a prior MRI, was definitely improved, and so I have let both of them go back to activity. There are several patients who presented to me with concerns for exercise intolerance and chest pain in the weeks to months following vaccination. And the ones that I did MRI haven't found any obvious evidence for myocarditis. But again, I guess it's possible that they could have had a mild myocarditis and then it resolved by the time we ended up getting the MRI. And now a little bit about children with existing heart conditions. So this is a patient population that we also worried about a lot when COVID first, when we first found out the effects of COVID on the heart. As far as patients with congenital heart disease, there isn't a lot of data available, but based on our center's experience and the few studies that I found, mortality seems to be quite low, quite similar to healthy children. However, just based on what the symptoms and sequelae are, we do expect that there are certain patients that may be at higher risk because they have perturbed physiologic state, particularly those with single ventricle and those with underlying heart failure. So those are patients that we would still be a little bit more concerned about. And then we do have a little more data on heart transplant patients. So this is my primary population that I follow. So the Pediatric Heart Transplant Society receives data that's submitted by every heart transplant center in the country. And for patients who are on the transplant waiting list, there were 56, that's this over here. There were 56 of them that had COVID-19 infection. There was 1 death and 4 with long-term sequelae, and 51 had complete recovery. So that's pretty good outcomes there. And then as far as post-transplant patients, we have a lot more of those. There were 623 patients who had COVID-19, 3 deaths, and only 14 that were either unresolved at 30 days or had long-term sequelae. 580 had complete recovery. We followed 36 patients here at UIHC with who are post-transplant, and actually 12 of them, so 1/3 of them had COVID-19, and only 1 actually required hospitalization. And I actually am not attributing the hospitalization to COVID, because he had COVID, and then about a week later, I think 2 weeks later, actually, he still tested positive for COVID again. Because it was so recent, but had GI symptoms, which I think were probably due to another virus. And then the patients on our transplant list, patients who have been on our transplant list at some point after the data, after kind of COVID started in March 2020, there's been 10 of them, and 2 of them had COVID, and neither of them required hospitalization, and 1 of them is transplanted and doing well. And really, we haven't had a lot of big issues. So, but again, we are still very cautious with this population, as they're kind of at higher risk in general. All right, that's actually all I had, and I really appreciate the opportunity to talk to you, and I'm happy to take any questions. Let me see. I don't
Thank
see
you,
anything in
Dr.
the
Khan.
chat.
Yep, nothing in the chat. Does anybody else have any questions for Dr. Khan?
I may have missed it, but what is the incidence of the post-vaccine myocarditis?
You know, that is data that I don't think I had, but kind of initially at the time when the vaccine first became available for the 12 to 18 group, then I think most hospitals across the country over those few months in the summer saw quite a few cases. We saw, you know, these 2 or 3 here, but there were most hospitals were seeing, you know, out of the big hospitals that I spoke to, you know, people had seen anywhere from like 5 to 10 cases kind of through the summer. And so it's not a very high incidence, but it was definitely very clearly associated with the COVID vaccine. These patients most of them, you know, got the second dose, and then it was a couple days later where they developed the signs of myocarditis.
Thanks.
All right.
Okay. Thank
Thank you very
Dr.
much.
Khan. I'm going to reshare my screen here real quick. Just want to say thank you once again to everybody for attending. As you heard earlier, we are very open to you know, getting your candid feedback on what you liked and also what you didn't like about this session, things that we can improve, either the didactics or the simulations, in order to make this the best experience that we can for you. In addition to that candid feedback, we also invite you to use the QR code that you see below in order to complete a post-session survey. I'm going to post another link as well in the chat. And so we're also hoping to gather some objective feedback. And in all honesty, this is being spearheaded by one of our fellows. His name is Chris. And this is his QI project for his fellowship. So if you want Chris to graduate in 3 years, please consider filling out the survey. If you want Chris to do a 4-year fellowship, please don't fill out the survey. But anyway, you have the QR code and the link there. And again, we appreciate feedback, both candid and objective. Is there anything else that we can answer or address for anyone before we end the session?
I hope Christopher was all nice to you when you all called at some point.
Okay, I'll leave this up for a few more minutes in case people are having trouble, another 4 or 5 minutes. But otherwise, thank you again for your attendance, and we look forward to seeing you again next time.
All right, thank you, everyone.